Well, good morning and good afternoon, everyone. Welcome to our webinar today on our guide to leveraging opportunities between Title V and Medicaid for social emotional development. We're thrilled by the excitement and interest of so many that have joined us. Almost 500 people have registered from across the states, from advocates, from Title V, from many organizations for the importance of this work. So thank you again for joining us. For everyone on awareness, we are recording and slides will become available after the presentation. The next slide shows I want to review our agenda for our webinar today. First of all, Kay, do you want to slide that forward? Thank you. I'm David Willis. I'm a senior fellow here at CSSP. I'm joined by my dear friend Kay Johnson, who will be providing a summary of the guide. As you know, Kay Johnson's nationally recognized for her work in maternal child health policy, researcher, advocate, and consultant. She's been active in Medicaid, EPSDT, health policy at the federal and state levels for many years, and we're eager for the work that we've been doing around this today. We also will be joined later in the day's discussion with three discussants, Kate Wilcox, who's Maternal Child Health Section Manager of the Oregon's Title V Director at Public Health in the Oregon Health Authority. She leads the state-level public health efforts in Oregon's prenatal and early childhood populations with a specific focus on groups of multiple health risks. She's also the past president of AMCHIP. We also have Brenda Blasingame, who comes from many years of experience in different roles in early childhood and leadership, not only from First Five Contra Costa, Director of Programs at the Tularis Institute, Thrive by Five Washington, Save the Children, Health Connect One, and now she's at the Pritzker Children's Initiative. She's engaged as a strategic leader of 20 years of experience in public health and nonprofit sectors about local and state and national levels. We're really excited to have Brenda with us. Then we also will have discussants from Beth Dworsky, who's with Family Voices. She's the Associate Director of Programs, has been a longtime leader for family leadership organizations, family-to-family health information centers, and brings a wealth of experience of engaging the family voice. And then I'll have an opportunity also to share with you my thoughts about this good work related to the child health sector in the medical home. We will be using the question and answer, and we welcome you, next slide, to suggest that if you have questions or you want something to be brought forward, add that to the Q&A and just hit your button and send, and that we will all see and attend to that in the Q&A section. And so I also want to acknowledge the indebtedness we have to the funders for the Pediatric Supporting Parents Initiative. We're also grateful to the 6 states, their Title V directors that were informants for us, as well as national experts and family leaders. And we really appreciate the review of others that have helped bring this guide to really the most meaningful information we can have moving forward. The next slide, I just want to call out again how the Pediatric Supporting Parent Initiative has been very, very instrumental in moving this agenda of social emotional development in pediatric care. The PSP initiative has been focused on cultivating healthy social emotional development in our countries for our country's youngest, especially vulnerable children, valuing the importance of the parents' roles and how that plays in their development, and seizing the opportunity whereby pediatricians really help better support parents in that role. So the background for this work has been guided by a number of different recent activities, one of which was the 14 common practices of the common threads, the report from the PSP investment. Then the Medicaid strategies identified by the blueprint, the high-performing medical home, and the source book created by Kay Johnson and Charlie Bruner, our work on early relational health at CSSP, and the foundational work that Einhorn Family Charitable Trust and NICHQ and the labs created around promoting social emotional development in primary care. All of this is within the frame of the Bright Futures Guideline. Next slide suggests at first We particularly focused from the Pediatric Supporting Parents Initiative, the report that was released in the fall of 2019 that described the 14 common practices that medical homes could implement to promote the social and emotional health of young children and parents. These practices were identified after reviewing over 70 evidence-based programs and conducting site visits. The practices noted were required nurturing parents' competencies and confidence, connecting with families to support and promote healthy social emotional development, and developing a care team and the infrastructure and culture to create a backbone that made it really possible to implement these innovative programs. In addition, this study identified the systemic barriers and challenges that prevented this practice from being universally accessible through pediatric care and the details and recommendations for each visit. So now we're really at a critical time where the opportunity for Title V Medicaid partnership to hold important opportunities to address these barriers and to accelerate innovation and transformation to promote the social emotional development and the role of pediatricians supporting parents. So this need has never been more urgent than in this current moment with the triple crisis. And we're really excited to bring to you the good thinking we have about the partnership that can be generated by the Title V Medicaid partnership to promote social emotional development through pediatric practices. So let me turn it over now to my dear friend and colleague, Kay Johnson.
Thank you, Dave. I really appreciate it. See if I can go here. So we're really going to talk about Title V and Medicaid together and apart, and really beginning with the points about why these programs are so important and so powerful, and why would, you know, in addition to all of the great work and the blueprint and the common threads and the NICHQ work and so on, why would we have yet another product like this out of the PSP initiative? Because Title V and Medicaid are the largest federal state health programs that serve young children, because they themselves are required under federal law to work in partnership to promote child health, because they're positioned to do that work, including social emotional development, and because without Title V and Medicaid, we really don't think that child health transformation is going to be catalyzed, and the improvements in pediatric primary care that can improve child and family outcomes in terms of social emotional well-being will not occur. Medicaid and CHIP obviously are this large source of financing coverage really for children. 35 million children, a quarter of all US children, are covered by Medicaid and CHIP together. And more than half of children of color are covered by Medicaid and CHIP. And if we look just at the children under age 3, it's about 40% of them, nearly 7 million infants and toddlers who have their coverage. And our appreciation to Georgetown for doing a special analysis for our guide to this point. What Medicaid does matters in terms of achieving equity. We need Medicaid to be a partner in achieving equity. We need Medicaid to perform in order to achieve equity and to have equitable access to care, to have equitable quality of care, to not have unequal treatment continue, and so on. And you can see here how well more than half of African American, Native, and Latinx Hispanic children, and just over 50% of other children and children who report of multi-race are covered by Medicaid. So how it performs definitely matters. Most of you know that the early periodic screening, diagnostic, and treatment benefit is the comprehensive child health package under Medicaid. That EPSTT sets the legal authority for virtually anything you do for children, and that it includes and requires comprehensive well child visits, diagnostic services, a focus on physical, mental, developmental, dental, vision, hearing, and other kinds of aspects of health and well-being, and coverage for a full array of treatment and interventions for children when medically necessary. So again, having states perform well in implementing this benefit is absolutely critical. Let's talk then a little bit about the role of Title V. Obviously, it is a large federal state partnership that is grounded in Title V of the Social Security Act for the past 85 years. One statutory purpose of the Title V program is to support access to children's preventive and primary health services. And of the dollars that states receive from the block grant allocation, at least 30% must be used for preventive and primary care services for children. And we have done an analysis of the current status of that in this work. The Title V efforts are to be done in collaboration with Medicaid, and we'll talk more about that. And that they have, because it's a block grant, the Title V programs have the flexibility to set priorities, and they are now in the process of finishing up their 5-year needs assessments and state plans, which are due this month. I think it's also important to remind us that the Title V program and those Title V dollars are an anchor for an agency. But the money that is spent through those agencies, through those entities in every state, is much larger than that. So this shows from the federal data, the federal state partnership. This is not the budget, but the expenditures. And it adds up to $6.5 billion. The largest of which is $2.8 billion in state funds in the gold, $2.4 billion in program income. Most of that comes from Medicaid, about $500 million or $532 million in the block grant itself. It's that small bright blue wedge. And then local funds and other funds, about a little over $300 million each. So when we talk about Title V, we often think, oh, it's just that little bit of block grant money. But in fact, it adds up to be much more than that, that can be leveraged. Notably, that 30% obligation to spend on preventive and primary care, it's only required for the blue wedge. And what we would like to see is that for the blue and gold and wedges, at least, that states were spending more on preventive and primary services. The federal law requires, each statute requires Title V and Medicaid to be partners. This goes back to the origin of the EPSDT program, the origins of Medicaid that tagged into and built onto Title V. And these relationships have been reaffirmed and augmented over the years in federal law. They're required to enter into interagency agreements to do coordination around EPSDT services. The Medicaid programs are required both to use Title V programs and to reimburse them for services for Medicaid beneficiaries. They are both obligated to coordinate and share information and data and to assure that there is no duplication of effort. I know that this is a slide that you can't read. We're going to go through each of these boxes, but what I want you to see, because as we go through the details, it's easy to get lost, that we're going to start with the medical home structure, talk about promotion, screening, prevention and support, and early intervention and treatment, a framework that builds along a continuum of opportunities. So the first area I'm going to talk about in that continuum, I'm going to give you examples of what could be done in primary care and the medical home. And our full guide will give you examples for every one of these about tools and models and programs. We're not going to go into all the tools and models and programs in the interest of time and attention today. But the first thing we want to emphasize along this continuum is aligning and advancing the use of guidelines, that well child visits be based on the Bright Futures guidelines and the EPSDT preventive purposes, and that they be aligned both through the work that goes on in the medical home and through the support of the state we'll talk more about later. And to advance the use of high-performing medical homes, to begin by advancing the medical home to align with the Bright Futures guidelines and other definitions for the medical home, and then to look at the opportunity for these more advanced, high-performing, team-based medical homes for young children in Medicaid in particular. Continuing through the continuum to talk about promotion. So what are the examples of what we think could go on in the primary care medical home? To use relational and family-centered strengths-based approaches to provide anticipatory guidance and parent education at a deeper level on developmental and relational topics. to use approaches for family engagement, to really be partnering with parents, and to maximize opportunities for families to connect with peer support. Continuing on just to talk about screening. So during the context of that well child visit, the Bright Futures Guidelines for the young children in particular calls for screening for general development, social emotional development, maternal depression, and social determinants of health, and about using validated tools and building it into a standardized workflow across a series of visits. We're grateful to the Child and Adolescent Health Measurement Initiative and a meeting that they convened earlier this year for generating an idea that we're calling the 6R response. That when a pediatric primary care provider is working with the family and that young child, they're going to show them respect. They're going to reinforce key messages and strengths. They're going to provide them with resources. They might ask them to return in a short amount of time to check on how things are going. They might give them a referral, and or they might be able to resolve the situation or follow through until it is resolved. We also think about this in the context of linking to Help Me Grow or similar systems utilities that can support those referrals. So just think of it like this for a moment. These are examples of screening tools identified by AAP, and the link is there across these categories that I mentioned. Just examples. Obviously, there are many more tools in the world. We just wanted to get a few in front of you today. And then that you would have that practice response to the screening using the 6R response and using Help Me Grow and similar structures across all of this. The 6R response is not just when you have a positive screen. Using the Help Me Grow and similar system structures may be in response to a positive screen. We then go into the prevention part of the continuum, and we're going to talk about universal and selective interventions. So we think that case management is defined as a part of the medical home core responsibilities for all children. And that integrating family specialists, an array of different kinds of people into practice and provide more universal support. And we have programs like Reach Out and Read and Dulce that are intended to be universal in that primary care setting. And then if we look further at more selective interventions that are still related to prevention, about case management and relational care coordination with tiered levels of intensity. So those who need more get more than the basic of medical home. And that you might have co-location or linkage to interventions and supports that are related to social emotional health and development, such as Healthy Steps, and that you would be linking to family support services, including community-based parenting programs and home visiting of the general nature. Then going into early intervention and treatment, whether we're co-locating services, and providing infant early childhood mental health consultation to the primary care providers, doing better connections with Part C early intervention, using the DC 0 to 5, making effective and efficient referrals to parent-child relational interventions or to parent-child dyadic mental health therapy, or integrating behavioral health into the practice, including services that are for young children. We're at that other end of the continuum. So let's talk about the levers for Title V and Medicaid to promote social emotional development in the context of this continuum. Generally, the levers are, similar to what we just talked about, aligning with and following the Bright Futures Guidelines, focusing on improving the medical home, financing services across the continuum, developing effective Medicaid contract language, clarifying what are the benefits, what are the billing codes, what are the provider qualifications, how is this going to be operationalized, using funds for training and QI projects, engaging with primary care providers. We think on both ends, Medicaid and Title V need to do much better at this. Engaging and informing and supportive families, again, a lot of room for improvement. And then collecting and reporting data on key measurement as well as aligning measurement approaches. So let's look at the details on this a little bit. I'll read all of these slides. We'll send out a a link to the slides and the recording of this webinar. We will send you a matrix, a table that shows you all these details I'm just highlighting today. So we're in the same continuum, back at aligning and advancing the use of guidelines, and how both Title V and Medicaid have the opportunity to do more to get into alignment with Bright Futures, to support training and QI projects that are related to the quality of well child visits, and to use their existing measures as well as to align existing measures. Then in advancing access to medical homes and developing high-performing medical homes, we think while states are reporting that they use a portion of that 30%, that they're using 30% of their Title V funds for preventive and primary care, we'd like them to dedicate more of that money to strengthening medical homes, to have projects about how to advance high-performing medical homes, to partner with pediatric providers, child health improvement projects, and parents to make this transformation happen, to use some of the strategies that they're now using to advance medical homes for children and youth with special health care needs, to support medical homes for young children without special health care needs, and again, measurement. And on the Medicaid side, parallel about creating incentives and payments and measurement that support this moving to a more high-performing team-based medical home. This is just quickly the diagram of the design that Charlie Bruner and I came up with, talking about how would you improve well child visits, how would you improve care coordination, case management, and how would you either embed or link to the other services. And most of these elements I've mentioned already. Continuing on our continuum, we're now beyond the prevention into this promotion side about using Title V funds to increase strengths-based relational positive interactions, encouraging the use of pre-visit tools, building on the work of family organizations, and funding projects so we can better engage families. We think that Medicaid could be reimbursing much better and more often for the work that's done by these various kinds of family specialists and community health workers and care coordinators. They have the authority to do it, but they're not doing it very extensively. And that they could permit provider billing more often for parenting programs than they do, as well as doing measurement about parent satisfaction. In screening and response, again, you see here the same 4 Bright Futures defined areas for screening around general, social, emotional, maternal depression, and social determinants of health. And both Title V helping to support the training and QI to get that done, and Medicaid doing a better job at both making their recommendations align and their contracts language align. Having a measurement of the screening and the response and follow-up on both sides, using their measures and doing a better job to align, as well as supporting Help Me Grow. And again, in prevention and support, to fund structures for training in the workforce, on both sides, again, that reimbursement of the people who are going to do this work. The Manat Group has reported on some efforts to finance Reach Out and Read, and we think that Title V partnering with Medicaid and the private sector could make sure that Reach Out and Read is financed for all children in a practice. And again, the parent education and peer support pieces are really fundamental. In the selective interventions, again, about Title V really knowing what's going on in terms of promoting the medical home for children with special health care needs, and how can they build the parallels for young children to make the medical home stronger and support the scale and spread of models that augment it through training and QI and a variety of other mechanisms. We know some states on the Medicaid side are financing tiered care coordination, but we need more of that for families with young children who have medical complexity, social complexity, or both. We're better on the medical complexity side. We haven't gotten to the social complexity side. And then providing enhanced reimbursement for those high-performing medical homes that use team-based care and integrate models, as well as using Medicaid financing to fund a portion of services. These roles in the early intervention and treatment end of our continuum, again, training and QI projects that improve provider knowledge, attitudes, and practices. Informing families is an obligatory function in both the Title V and the Medicaid statutes. Telling families about the role of EPSTT and financing their services, both preventive and treatment, and much more could be done there. And building the right contract language to support this work. Title V in some states is, and in more states could be, building on and sustaining the lessons that were learned from Project Launch, and to increase workforce capacity. On the Medicaid side, clarifying that there's coverage of these interventions and treatments for young children, including those without diagnoses. Diagnosis for these young children should not be a barrier to payment. There are other ways to determine medical necessity. To reimburse for the kinds of things we mentioned earlier about infant and early childhood mental health consultation to the primary care provider in the medical home, the dyadic therapy under the child's number, the integrated behavioral health, and mental health and other health-related services, and Part C early intervention. I'm just going to mention we're only showing you a portion of what the guide covers. Real quickly on elements that we might address in contracts, ink marks, invited George Washington University, contracted with George Washington University to do an analysis out of their database on current managed care contracts about what's going on in young child development, the high-performing medical home and healthcare transformation for young children. And Charlie Brunner was good enough to let us use some of those examples that supported this particular goal around social emotional development. So what the bottom line on this slide is that there's a lot of existing language that could be modified to build into the contract language that supports what I've just described. So there is language in many contracts about the medical home for children with special healthcare needs. That language could be modified for other children, for these young children with higher performing medical homes. Again, there's a lot of collaboration about children with special healthcare needs and issues around EPSTT and treatment, and more could be done to broaden that. There is screening language, but it is not including the full range defined in Bright Futures. A lot of them talk about social determinants of health screening, but often they only are focusing on screening adults. They do not often enough specifically mention parenting education. They talk about anticipatory guidance right out of the federal statute and really not today's understanding of it. That the medical necessity definition, if it's in the contract for these children, include prevention, maintenance, correction, and amelioration. That again, these care coordination elements, quite a number of states have those kinds of provisions for children with special healthcare needs, or for high-risk pregnant women, or children who've been exposed to lead, and those could be broadened to apply to others. A collaboration with Part C early intervention programs is mentioned only in a subset of contracts that, of all of the contracts that were reviewed. Collaboration with an array of community-based providers and entities tends to be on the adult side more than on the child side. And then using all of the child health measures, it's kind of spotty, those that are listed and those that are not. And we'll give more examples of this in the guide. So just to wrap up here, we think there are three important destinations or directions for change. And I've mentioned each of these, but let me start at the top and again and restate that there are strategies today used to support medical homes for children and youth with special health care needs that could be applied to a greater percentage of children to create and advance high-performing medical homes for young children. In primary care, we have a lot of emphasis on the physical aspects of care, and we could have expanded efforts to promote social emotional development and relational health in those settings. And then in terms of mental health, more focus on promotion and prevention linked to primary care, that infant early childhood mental health efforts are not as strongly linked to the medical home as they might be. We think improvement in each of these directions would make for a huge shift overall. So starting now, this month, take some strategies out of what we presented and out of the matrix we're going to share and put them in your state action plans this month for Title V to leverage your Title V and Medicaid interagency agreements, and that overall, now and down the road, in partnership with pediatric primary care providers and parents, the state Title V and Medicaid agencies can transform the medical home for young children through practice, finance, and measurement. Thanks to Charlie for defining those areas. Focusing on infant early childhood mental health efforts that are growing and have grown in states all over the country where you've been developing your workforce. Let's get that workforce and those strategies connected up with primary care. That having primary care providers and medical homes partner with parents to promote social emotional development is going to be essential. And then supporting the linkages to or the integration of services across this continuum of promotion, prevention, early intervention, and treatment related to social emotional development and mental health that'll have payoffs in the long term. Dave, I turn it back to you.
Thanks so much, Kay. And now we're going to move into our discussion section where we've asked our individual discussants to give their reflections and thoughts about the guide as well as this space. And so, Kate Wilcox, may I turn to you first?
Sure. Thanks, everyone. Good morning, good afternoon, wherever you are across the country. I'm Kate Wilcox. I'm Oregon's Title V Director. And I think what I want to bring to this is just re-emphasis and a reiteration, a lot of what Kay has talked about from someone who is operating on the ground, so to speak. We have two really important leverage points. The first one is really Title V itself. It is so much more than just the block grant. I think the pie chart that showed, the section of what those expenditures are, that blue wedge, looks small, but it's a really important piece of the puzzle. It is unlike any other piece of federal funding that we have. It's not categorical, it has some framework around it, but it's incredibly flexible. And so it's more than just the national performance measures. Although within the national performance measures, you can look at strategies that support those that link to what we're talking about here in terms of social emotional support and connectivity with that, the pediatric community and the medical home. Another piece of it is that we have the unique role of really being kind of at that system level perspective, looking across community health, what's happening in the community, what would it take to make some connections. And I always talk about Title V, we are sort of the glue, we are the connectors, we're like those nodes in those webs of social interaction, right? Where we convene, we connect, we bring that systems perspective. It's easy for other parts of the system, be it pediatric practices and pediatricians and Medicaid, to really be experts in what they do. And our job is really to elevate and see how they all connect. And that requires that we get to different tables. And those tables are really, really important. So Kay talked about a couple of them. If any of you in your states have a pediatric improvement partnership, there are over 20 across the nation. That is an excellent table to be at, to be able to connect that larger population health and that community health with the pediatric community. Another one is, are you connected with your AAP affiliate? I mean, that is a really important relationship. And I talk about, in Title V, we are the relationship people. And so going out and building those relationships is really important because we are the ones who can really make that difference. And that is the beauty of the block grant. That is the beauty of the Title V program, is the flexibility. The other part is, what are we learning from our children and youth with special health care needs programs within Title V that they do so well that we should be amplifying throughout all children. We talk about how if we do it well for children and youth with special health needs, that we're doing it well for all children. And while that's true, we have to then make that connection, make that leap to taking it out. And one of the examples is elevating that family voice. And Beth is going to be talking about that. What they do so well, what you all do in the children and youth with special health care needs work, we need to then amplify and put into all families and work with all children. The other lever I want to talk about is that partnership with Medicaid. Kay talked about how we have these memorandums of agreement or memorandums of understanding. They are required, Medicaid is required to have one with Title V, just as Title V is required to have one with Medicaid. And these are amazing pieces. I know it didn't come up so much in the earlier days of Title V, but it was always a requirement. And about 5 years ago, there was a real push from the Bureau to get those MOUs in place. And it really is an important lever. It is, again, that relationship piece with your Medicaid policy team and the Medicaid systems team, and figuring out what are some agendas that you can work on together. So for example, what would it look like if Medicaid paid for home visiting? What would it look like if Medicaid paid for early childhood mental health? What would it look like if Medicaid was able to pay for parenting education? Those are the tables where you can have those conversations because everyone comes with a different worldview, and how do we come together and find that common ground? Another area that was talked about is, the idea of social determinants of health, the social emotional development, maternal depression. How do we elevate those within a Medicaid program and create accountabilities and measurements so that there are incentives around which to move upstream and really have the data to show how if you move upstream, you're going to have better outcomes downstream. And this is all part of our work. We know this, but it's being that connector, being that relational person, being that relational program that can pull it all together. So those are a few of my thoughts. I look forward to the questions and answers. Thank you.
Kate, that was spectacular. Thank you for your comments. Brenda, may I turn to you, please?
Absolutely. Hello, good morning, good afternoon, good everything to everybody. For the next few minutes, I want to share some thoughts about this work and addressing inequities. I ask that you be open and that you take what I say as food for thought or a reminder as you think about the flexibility that exists in your Title V work. I love this quote from Maya Angelou: "Do the best that you can until you know better. Then when you know better, do better." I think that we all know better, but we're not doing the best across the board for all children, their families, and communities. We know the data, and at this moment in time in 2020, not only do we on this call know the data, but folks across the country are waking up to and understanding in a very different way. Because 2020 has laid bare in a new way the issues of poverty and food insecurity, housing insecurity, systemic and institutional racism, and the intersection of poverty and racism. The American economic and cultural landscape has completely changed, and it's brought equity and racial justice to the forefront of our national conversations. And as Kay said earlier, Medicaid matters for achieving equity. I think we really have to think about how we can change our mental models. If 2020 has shown us nothing else, it's that we have to be willing to do it differently. We have to be adaptable and flexible and find another way when the way we are going is not getting the results that we want. And I think that the best news ever is that we created what is, and we can choose to change what is so that it becomes something different and something better. So you have the power and the choice. And so I want to encourage us to exercise and use both of them. Here's some thoughts that I have of 4 particular things in relation to what we've been talking about. Not in any particular order, but at a high level that I think we need to be thinking about, working on, and acting on. And I see these things as really connected and mutually reinforcing. And this is in no way an exhaustive list of all the thoughts I have about what we can all do together. The first one is that it goes without saying that it's important that we keep saying it and reminding ourselves and focusing on it, that we have to center equity and social justice. We have to open the doors and windows of access and opportunity, engagement, and uptake of supports and services for everyone, particularly for those who have been systematically marginalized and locked out. If we center and ground all our work in a foundation of equity and social justice, then we will be moving towards the higher levels of inclusion, which leads to the greatest good for the greatest number. I really strongly believe that focusing on equity and social justice in the end makes it better for everyone. The second thing I want to talk about is really employing the use of targeted universalism. Our system has created a number of disproportionalities that have been created through our responses and how we've set up our system. So our responses have to be disproportionate to change the context from what it is to what it can be and should be for everyone. Yes, we know that universal approaches are very important. It takes away the stigmatism that often is felt by families and parents. And we know that there are communities of people that have many obstacles, challenges, and barriers. And we want to make sure that we continue working intentionally to create systems of services and supports that eliminate or mitigate those barriers, obstacles, and challenges. So by employing targeted universalism, that's exactly what we can do. We can put the resources where we know they need to go at a higher level so that we can begin to move the needle in the ways that we want to. The third thing I want to say is I want to encourage us to think more intentionally about two elements of the work. Engage and inform and support families, and collect and report data. I want to say that it's simply not enough to do what these statements say. I want to invite us all to elevate and expand our thinking around both of these things. One, centering parent, family, and community voice, wisdom, and leadership so that we co-create the solutions in partnership with families, not just through a focus group or a survey. We have to do this much more than we've been doing it so that parents are involved in the decision-making process of what gets implemented, not just in the early pieces of that, but in the decisions. The second part is about the data. It also should be totally inclusive of community because the data is about their lives and their community, of the parents and the families that we're working with. Engaging in a discussion about the data, the story it tells, not just from our point of view as the professionals, but from the vantage point of parents and community that are the ones that are actually using the supports and the services. I would add that we have to lean in, I think far in, way over probably where we see our edges and our limits on these two things. It really is about the Latin phrase that translates in English to nothing about us without us. We have to endeavor ourselves to live into that statement. Lastly, I want to say that place matters, relationship matters. You just heard Kate speak about relationship. Trust matters, and racial, cultural, and language concordance matters. We have to work with community-based organizations that are rooted in the community where our families live. And these organizations have to be trusted by the community and employ trusted individuals from the community. And whatever we call those individuals, community health workers, promotores, community-based doulas, peer lactation support counselors, paraprofessionals, we all have to push ourselves to think differently about who needs to provide services. Licensed and degreed professionals have their place, but we sometimes do over-medicalize, clinicalize, and pathologize things. I'm sad to say that the phrase, "it takes a village to raise a child," has become part of our lingo. And I feel in some ways we've really lost the meaning of that African proverb from Nigeria and from the Igbo culture. And that it's really about, it takes an entire community of people working together for the community's children. And that if we can focus back on that, we can really make a difference. Anthropologists know that through 99 years of human experience that children have grown up in community. Paraprofessionals can be an important part of the recreation of the village and the community for so many parents and children that are marginalized and struggling as a result of that marginalization. It really is about peer-to-peer supports, social capital, and social connections. I think that we are all leaders wherever we sit. Being a leader is not solely about position, it's about taking responsibility for something that you care about and working to make whatever that issue or topic is you care about better than it is or was. So now we loop back to where I started from. If we know better, we have to do better. I challenge all of us to lean in and work to achieve transformation as a result of the work that we are doing. And I look forward to having more of a conversation about this.
Brenda, thank you so much for not only your challenge, but your wisdom and these important reflections for us. And let me move now, Beth, your perspectives, please.
Well, first, thank you, Brenda, because you pretty much said it all that I was going to say. Just thanks in general for the invitation to share some information about family engagement today. Family Voices was pleased to partner with the Center for the Study of Social Policy in many phases of the pediatric supporting parents work, and to have engaged and supported family members who represent the target population of the PSP initiatives, meaning families of young children who are diverse by race, ethnicity, gender, geography, and other socio-demographic factors. Families are at the center of these three systems of care of Title V, Medicaid, and medical homes. And so it's critically important to engage families, as David said in his introduction, in building a stronger and more equitable service system. So when I think about family engagement, I'm always reminded of Surgeon General Koop's recommendations for achieving a comprehensive, coordinated, family-centered, community-based service system for children with special health care needs. And his recommendations included improved facilitation of parent-professional collaboration at all levels of healthcare. So between the child, family, and provider in program development, implementation, and evaluation, and in policy formulation. So Dr. Koop made these recommendations in 1987. I often find myself wondering if we're there yet, and I realize that there's still a lot of work to be done towards improving both the systems of care and family engagement, which echoes what Kay said, that there's room for improvement. And while it is most common for systems of care to engage families of children and youth with special health care needs, and the Maternal and Child Health Bureau has been a champion of family engagement in the Title V programs, all families have important contributions to make and can use their lived experience to improve Title V programs, Medicaid policy, and medical homes for all children. So again, kudos to CSSP for recognizing that as they set about to do their work to identify best practices and sort of like the critical elements, that they recognized how critical it was to not only engage families, but also to partner with a family-led organization such as Family Voices to support the families with mentoring them and also providing financial compensation in recognition of their time and expertise around using their lived experience with primary care to improve policies and practices around the delivery of primary care to improve social and emotional social and emotional development of young children. Compensation also is a huge equity issue, as not every family has the luxury to take time off of work or away from their kids, or in days when we actually had meetings in person, to travel to meetings, pay for gas and parking, etc., in order to participate. So when you make a decision not to compensate families, you're deciding who will be at your table, and it is not necessarily the families who are representative of the population that will be served. So in addition to doing the individual interviews with 4 family leaders for this work, as part of the blueprint work with the 8 Medicaid implementation work group states, we did do focus groups with families. And what we found in the individual interviews, as well as in the focus groups in all 8 states, is that There is a lack of trust between families and their primary care providers because visits are so rushed and there's a tremendous lack of attentiveness to family culture. One family leader shared that families from diverse cultures don't necessarily make the connection between developmental screening and how playing, reading, singing, all those activities that families do together can help promote their child's social and emotional development. So following up on what Kay mentioned about the importance of engaging and partnering with parents as part of the universal health promotion, there really needs to be time to develop a trusting relationship in order for families to make that connection between what happens clinically on like a checklist of a developmental screening checklist and what families are doing at home and in their communities with their children. And to that, developmental screening really needs to be more than a checklist on a clipboard that families fill out while they wait to see the doctor. And often, and across all 8 states, we heard from families that there is little or no discussion of the results and few referrals, mostly because primary care teams really don't know where to send families. I mean, one family shared that they learned more about community supports, things like food pantries, equipment loan programs, free book programs, etc., by seeing the flyers on a bulletin board while waiting for her tires to be changed than she did at her pediatric office. So, and families also learn from each other. Just in the 1-hour focus groups that we did, there was a sense of camaraderie. For example, when it comes to EPSDT, families are they need not only to know more about the benefit, but why the benefit is important to their child's social and emotional and overall health and well-being. And, you know, things like the transportation benefit that's in EPSDT, a lot of families didn't know about that. And we had families telling each other, email me after this, I'll hook you up, I'll get you that form, I'll explain it to you. So families, you know, again, this is nothing that all the other speakers did not say. Families need peer supports, and some of the best, and if that is not a capacity that a primary care office has in order to provide families, connecting to community-based organizations and family-led organizations in the community or the state where the practices are is a great way to make that happen. Because family-led organizations, they may not always know where to send a family, but they'll work really hard to figure out where the family can get the information they need. And they can also help individual families navigate complex systems of care and develop. A lot of times it just comes down to the fact that you might not feel comfortable asking a question to a doctor or saying, is there a second opinion? Is that the only way to do something? Is there a better way to make this happen? And it is a way that families can get encouragement for their role as their child's advocate when it comes to making decisions about health care. It's also really important connections to family-led organizations, in addition to providing mentorship and support. A lot of times they can recruit and orient families to their roles so that they have the confidence, that they have the information, so that they know the rules of the game if they are going to sit at decision-making tables and co-create, as Brenda said, co-create solutions to the problems that they see in the system of care. And I think that family engagement is when we talk about key levers, I think that engaging families both at the individual level of care and in policy making and quality improvement efforts, in refining how practices work, is a key way to drive change from the bottom up as well as from the top down. Because at the top, you're leveraging the Title V Medicaid MOUs to create changes in the medical home. And at the bottom, having medical homes engage families in individual care and in advisory roles can drive change from the bottom up, and hopefully we'll just meet in some utopia of medical care in the middle that works for all families. That I think at this point, I'd like to hear from the questions and answers that people may have.
Thanks so much, Beth. And let me, conscious of coming towards the end of our time, let me just share a few reflections about the medical home itself. We've been talking all about how this guide can help leverage Title V Medicaid to promote social, emotional health within the medical home. A couple key points. One is we are in such an unprecedented time of child health change, mindful of the triple crisis. The child health medical home platform touches most all families still. Thereby, it's an incredible access point for linking and coordinating. The opportunity of Title V Medicaid partnerships as leverage to expand, transform, and better serve families has never been more visible and, I would argue, needed. And as Kate Wilcox said, Title V is the glue. It's a relationship piece. It is how it is that the alignment between Medicaid's financing opportunities and their goals and the goals of the needs of families and communities can be brought to the doorstep of the medical home to achieve its goals too, of promoting social emotional well-being for children and families. That linking and coordinating with communities and the community supports is the huge opportunity of the partnership that can be built between Title V and Medicaid. The other thing I want to bring out is child health practice is keenly aware of the central focus on promoting social emotional well-being. Not only currently are they witnessing the stress that families have around social determinants, knowing how that's impacting stress and thereby future social emotional well-being of young kids and families, but also all of the science has pushed them to recognize that relationships really matter. What's being called foundational relationship work or early relational health work, and what is really growing about recognizing that providing strong, supportive relationships young builds better health and developmental outcomes. So the field of pediatrics and the child health platform is keenly aware of how do we promote social emotional well-being. Ever more are they ready for the leverage opportunities that a Title V Medicaid partnership to particular levels of activities will be heard and will be ready. I think it was commented by Kate too, the connecting with chapters, chapter leaders and pediatric leaders in terms of how the leverage opportunities can be played through has been tested in many states. We know it works, and evermore this moment in time would make that be helpful. Using the lever of quality improvement and pediatric improvement partnerships as part of the lever of change is really essential. Yet I want to go to what both Beth and what Brenda brought forth, and this incredible opportunity and necessity of partnering with families in authentic relationship building, and in terms of bringing the voice of families as partners to medical home transformation. That has never been more important. And building the leadership of parents with practices and doing the hard work of conversation, dialogue, and transformation to become much more equitable and advancing racial justice. There's never been a better time of building those opportunities to achieve the transformations that are really essential for families. One more thing to comment on, and that is the opportunity to build a relational health workforce. And how is it that Title V Medicaid partnerships and communities with the medical home could envision all the relational connections that can be made to improve social emotional well-being, not the least of which is within the medical home. So I'm going to stop and recognize that we have just a couple of minutes to touch to some of the questions. This has been thus far an incredibly important conversation. So Kay, can I turn to you to address a couple of the questions that you see as being most important?
Yes, I did type some answers in the chat, but let me just emphasize three things. Number one, every state has a Medicaid Title V interagency agreement or MOU. They are all, every state is required to submit those to the Maternal and Child Health Bureau, and the last round of them is available at the MCH Bureau website. The National Academy for State Health Policy and others have done analyses of these, but the latest versions will be submitted by states this month to the Maternal and Child Health Bureau with their state plans. So Ask around. They're definitely, your state definitely has one, and you can go click on a map on the web and get it down. They're quite generic, and they are broad levers for saying there is a relationship, and special projects and activities have to be built underneath them. They're sort of durable major contracts. The second thing is a question about preventive services. I want to parse that into two pieces in the 30 seconds we have here and say, prevention services are at the heart of the EPSTT child health benefit in Medicaid. They are the essence of what Medicaid is most intended to start with for every child who has its coverage. When you ground those services in the medical home, in pediatric primary care, you begin to build the mechanism for financing. I think often people, and this is to someone else's question, often people come in and say, how do we fund our model? How do we fund our model for home visiting? How do we fund our model for early childhood mental health treatment? How do we fund our model for parenting? It's not about how you fund your model. It's about how you build a system and you leverage all of the dollars, the Title V dollars, the health agency dollars, the private sector flexible funds. When I worked with Jane Itzer, we called it spending smarter. Don't come with the question of how do I fund my piece? Say, where does my piece fit into this? What are the levers and the array of things that we can use to do that? So David, I think we are at time.
We are, and I want to thank all of you that have attended today of strong interest to the guide to leverage Title V Medicaid partnership. The recording will be posted on our website. The framework will be also available there, and within some weeks after that, we will be having the full report that will become available. So as Beth said, let's imagine this utopia. Let's take this guide to leveraging these opportunities and go forward and do good work towards the vision that we all share. So thanks to everyone for attending today, and Godspeed to all. Thanks.
Thank you.